So, thank you, Philip, thank you, Andre, and for all of us, thank you, Jan, for inviting me to be part of this renowned faculty and to have the opportunity to speak to you about an issue which is of interest for me and also for my staff since a couple of years. And I have also collaborated with companies which are engaged in the field of hemodynamic monitoring. So, my outline, I have to answer the question, do we have to react on fluid responsiveness in the OR? And I will give you three different answers from three different viewpoints. I will answer this question as an academic teacher. I will answer this question as a head of department, which is actually not the same. And I will answer this question from the viewpoint of a resident in my department. So let's start with the academic teacher. This is a study which I had the pleasure to do with some friends throughout Europe. And it was a study in patients undergoing major abdominal surgery, colorectal, urological, gynecological procedures, 160 patients, multi-center, Germany, Hungary, Spain, and Russia. Duration of surgery longer than 2 hours and or a blood loss of more than 20%. Of total blood volume expected for enrollment. The primary endpoint, length of hospital stay, and secondary endpoints, incidence of complication and organ dysfunction. And as you can see over there, an important part of the algorithm applied in the intervention group was indeed pulse pressure variation. So a so-called dynamic variable indicating fluid responsiveness. And responding to this pulse pressure variation, we followed the path and we tried to get a cardiac index of at least 2.5 liters and a map of at least 65 millimeters of mercury. And then we went through this algorithm. We gave inotropes and fluids dependent which variable we had to respond to. And at the end of the study, and it's always good at the end of a study to get it published, there was indeed a significant difference in favor of the study group with respect to the number of complications and also the number of patients who experienced complications. The funny thing, however, was that there was no difference with respect to the fluid balance or the total fluids administered throughout the study period. And we had indeed a main difference with respect to dobutamine, which nearly half of the patients in the study group received and no patient in the control group. So it seemed that the success of the study was mainly driven by administering a positive inotrope drug and not administering fluids and not responding to fluid responsiveness in the OR. And unfortunately, except of the study which I presented you with a positive result, there are also studies out, such like this study, done also in patients undergoing major open or laparoscopic colorectal surgery. And the authors, they grouped the enrolled patients in patients who were aerobically fit, the majority, or unfit based on performance during a cardiopulmonary exercise test. And then these patients were randomized to receive a standard fluid regime with or without esophagus Doppler guided intraoperative goal-directed therapy. I won't go into many details here, but it turned out, unfortunately, that the patients in the control group tended to do better than the patients who were assigned to the intervention goal-directed therapy group. It was not completely significant, but the trend, and the trend is always your friend, so the trend was against the goal-directed group. This was really puzzling for all, let's say, the people believing in goal-directed therapy, and I was a person who was also believing in goal-directed therapy. The conclusion for the study with a negative or neutral outcome was, for me, the patients were filled with volume regardless of fluid responsiveness. There was no reliable method part of the algorithm. And the goal-directed patients received during 3-hour surgery 5.2 liters of fluid, and their fluid balance totaled some 4.2 liters. In conclusion, for this negative study, the goal-directed algorithm led to a liberal fluid strategy, and there was no assessment of the patient's position on the Frank-Starling curve. So puzzling results, differing results, and it may pay to look at the largest trial performed to date in this group of patients, more than 700 patients, high risk, older than 50 years, undergoing major gastrointestinal surgery at 17 acute care hospitals throughout the UK, highly published in the JAMA. And they also used a goal-directed protocol, fluids and dopexamine, during and up to 6 hours following surgery, or so-called usual care. And the primary outcome was a composite of predefined 30-day moderate or major complications and mortality. So the fluid balance, interestingly, did not really differ between groups. You can see it over there, that during surgery, the cardiac output guided hemodynamic group even received less fluid, approximately 1 liter less than the usual care group. But afterwards, it balanced out, and during surgery, the patients in the goal-directed group received more colloids than the usual care group, and afterwards they received colloids, while the control patients received no colloids at all. And if we sum it up, there was no big difference with respect to the fluids which were administered. And maybe the explanation for this is found in the appendix in the supplemental materials to the study, where it reads, clinicians retains direct discretion to adjust therapy if concerned about risk of hypovolemia or fluid overload. And second, very important, we will see later on why, fluid responsiveness is defined as a stroke volume increase equal or more than 10%. The question is, were these patients really at high risk? High risk was defined in this study as one of several risk factors. One risk factor was age above 65 years. So are all patients older than 65 years really at high risk? I would doubt this assumption if I look at Michael Pinsky. So we can see here that a large proportion of patients indeed were ASA risk classes 1 or 2. So again, I would doubt if they were really at high risk. Unfortunately, again, in this largest trial out to date, there was no difference between the intervention group and the usual care group regarding any of the observed primary or secondary endpoints. So again, a negative study. But finally, the authors, they were very unhappy with the results of their trial, and then they just added a meta-analysis to their paper, including the results of their trial, and then afterwards they were really happy with the study, because then, indeed, we had a positive signal incorporating the results of this large trial into a meta-analysis. It turned out that, indeed, goal-directed therapy intervention did better than control patients. So, really convincing.
The editors asked them to add that at the end.
Okay.
It's not them. They were requested by the editors to put it in.
We have another issue with all these trials, the question which endpoint we should address. This is a meta-analysis from Mark Hamilton, Maurizio Cecconi, and Andrew Rhodes. And they investigated randomized clinical trials that evaluated the use of preemptive hemodynamic interventions to improve surgical outcome, 29 studies, a lot of which reported surgical complications, more than 4,800 patients. And what these authors found, that indeed if we look at goals, we only see with a positive result a goal which aimed to increase cardiac output or oxygen supply. No other goal had a positive impact in this meta-analysis. Fluid responsiveness is not mentioned at all as a positive factor in this array of successful variables. And then we have to face a basic truth. And this was a study, a very elegant study published in the British Journal some 3 years ago in relatively healthy patients. And these patients were challenged by passive leg raising before or at admittance to the hospital and a TTE, and after 8 hours of fasting. And the primary hypothesis was that 8 hours of preoperative fasting does not increase the proportion of patients with a positive passive leg raising test. And the secondary hypothesis was that echocardiographic filling pressures or stroke volume are not affected by preoperative fasting. An important study because the belief is that a patient who has to fast some 8 hours has a fluid deficit, and that has to be filled up by us rapidly upon induction of anesthesia by giving some 2 liters of crystalloids. My hypothesis is that many patients are able to maintain their fluid balance without us anesthesiologists filling them up with 10 liters of crystalloids, because they have the capability of maintaining fluid balance by themselves. This was the study design, passive leg raising, echocardiography, before and after fasting. And as you can see here, editor's key point, clinicians often assume that routine preoperative fasting contributes to hypovolemia before anesthesia, and it's not true. Routine duration appears to have no significant effect on circulating blood volume. So we have to admit that fluid responsiveness is normal. It's common in our patients. It's not pathologic to have fluid responsiveness, and it has not always to be addressed because it's normal. That's a very important sign of this study. We have the industry also with us here, our partners, and nowadays it's possible to have in a relatively cheap and common hemodynamic monitor dynamic variables incorporated such as PPV. For instance, this is a screenshot from a GE monitor from my department. I get not paid for this sentence. So it's a GE monitor, but it offers a PPV as part of the routine monitoring. Does the PPV, does dynamic indicators like PPV or SVV does help? Does they help? So it's a question not of white and black, it's a question of the gray zone, as we have learned from this paper from Maxime Canesson. They took patients from different studies, in total more than 400 doing general anesthesia and mechanical ventilation out of 4 centers, and then they assessed PPV, central venous pressure, cardiac output, before and after volume expansion. And the response to volume expansion was defined as more than 15% increase in cardiac output after volume expansion. And then they used a relatively complex mathematics to assess or to identify a so-called gray zone. What is a gray zone? This is the relationship between the PPV at baseline and the change in cardiac output after volume expansion. You see, there is a relationship. It's not as strong as we have believed before, but there is a significant relationship. But you see this gray hatch there. It's between 9 and 13% of PPV at baseline. And what these authors concluded is the gray zone approach applied to PPV for prediction of fluid responsiveness in mechanically ventilated patients during general anesthesia identifies a range of PPV values between 9 and 13% for which fluid responsiveness cannot be reliably predicted. And such values may be seen in approximately 25% of all patients. This is bad news for us in the OR, because it means not only we cannot use 25% of patients, but we have many patients with arrhythmias. 25% also high-risk patients. So it may be that in up to 50% of all patients in our ORs, dynamic indicators cannot be used appropriately. The very good thing of this study, there are many good things of this study, but the very good thing is that they also added a separate analysis where they addressed the risk-benefit ratio. So they said, okay, if the risk of treating a false positive result is higher than the risk of treating a false negative result, then you should go much higher with your PPV values to whom you will react. So if fluid overload is a danger for the patient, be very conservative with your PPV values and start, let's say, at 15% as a start signal for giving fluid to the patient. Second possibility to assess fluid responsiveness in the OR, on the intensive care unit, is a famous passive leg raising maneuver, which I've introduced to you in this study addressing the fasting. This is a meta-analysis some 7 years ago, and they grouped 9 papers, and they addressed the response of passive leg raising on the cardiac output. This is CCO versus the response of passive leg raising to pulse pressure. If you have no cardiac monitor in the patient, you may assess the reaction of the patient's blood pressure, specifically pulse pressure, on this maneuver. As you can see very clearly here, if you have continuous cardiac output, the passive leg raising maneuver is very specific to indicate that the patient will increase his cardiac output if passive leg raising maneuver was positive. With the pulse pressure, it's not such specificity, but still it's a useful indicator to assess if a patient will increase his cardiac output after a passive leg raising maneuver.
Okay.
Kannst du einmal bitte die Beine hoch machen?
Ja,
So.
ich mache jetzt die Beine hoch. Achtung, Tisch bewegt sich.
Unfortunately in German.
Ja, ein bisschen weiter noch. Das muss. Ja, danke. Okay.
Also jetzt soll ich
Kann
mal, wie soll ich denn jetzt arbeiten? Das funktioniert nicht.
Okay. I will not translate the other things which Sheridan said. I will only say that passive leg raising in the operating theater may be difficult. So it's not a very useful maneuver to assess fluid responsiveness in the OR. And I'm only talking about the OR here. The second thing is, okay, you don't need passive leg raising, you don't need dynamic variables, you do it like NICE recommended. You go for stroke volume optimization, you monitor stroke volume, you give some fluids, and if the stroke volume increases, yes, you repeat it, you repeat it, you repeat it, unless the stroke volume does not increase anymore, and you will react on each decrease of stroke volume by again giving the patient some volume. And this is a thing which has some methodological issues. This is a paper from the same group from Rupert Pierce, a paper published in Lancet Respiratory Medicine. They did a comparable study, also tried to address oxygen delivery, and then they wrote in their own paper in the appendix, changes in cardiac output of more than 14% can be reliably detected by this technique. Their algorithm told us to give fluids if the stroke volume increased by more than 10%. So this is contradictory, to be honest. This may have, let's say, added to the missuccess of the study of Rupert Pierce, because the technique was not able to reliably detect a 10% increase in stroke volume. And the same thing is true for the Doppler. It's a paper of Julian Hart. The sensitivity of a 10% decrease in esophageal Doppler measured SV in identifying fluid responsiveness was only 37% in our study. And our data indicate that reductions in stroke volume of more than 10% as measured by Doppler can be related to other factors aside from preload. So we have an issue here with the 10% margin. And again, as a safety issue, I would always recommend to go for 15% at least as an indicator of a positive reaction of a patient on a fluid challenge. Also, a fluid challenge may be difficult. So normally a fluid challenge should be applied in 10 minutes or so, 5 minutes even better. But you see, the problem here is that we have sometimes cannulas with a very low rate of flow. It can take you hours to give such a fluid challenge, and then it's not a challenge anymore. So also you have some practical methodological issues with a fluid challenge in the OR, because you're not able to get sufficient flow rate into your patient. And the next interesting thing is what we do in daily clinical practice with our patients. Patients with intraabdominal surgery, 2 university hospitals, uncomplicated course with minimal blood loss. And then the authors assess the variability of fluid administration between anesthesiologists and between different procedures. You can see here the 2 different hospitals. You can see here different procedures, and you can see here the huge variability between hospitals and between patients. So you can have some 30 mLs per kilogram per hour for the same procedure, where in another hospital with another anesthesiologist the patient gets some 2 milliliters. This is really unexplained, and it's dangerous for the patients. The authors concluded, despite recommendations in literature for fluid management, we find a large patient-to-patient variability in fluid administration between and within anesthesia providers. And they also say the regression model analysis showed that the strongest predictor for corrected crystalloid infusion rate for a specific patient was the anesthesia provider and also the surgeon. So sometimes the surgeon, he asks for fluids. Is this important for the patients? Let's look at this study. Over 90,000 patients, non-cardiac surgery at a university hospital and 2 community hospitals. The primary variable was total intraoperative amount of crystalloids and colloids, primary endpoint 30-day survival, and some secondary endpoints such as pulmonary edema, reintubation, pneumonia, or respiratory kidney failure. And as you can see here, these are quartiles or quintiles of fluid administration. It's like the theory tells us. If you overfill the patient, you will kill him. You have postoperative respiratory complications, kidney injury, hospital costs, and length of stay all increase significantly. And on the other hand, if you don't give any fluids, you may also increase mortality and all these complications. So it's really, fluid administration is a key issue for our patients. It's influencing mortality, a very, very, very hard endpoint. So therefore, I would make a statement in favor of a very conservative approach to fluid administration. The price you have to pay for overfilling the patient is you will destroy the glycocalyx, and for a very small increase in cardiac output, here the purple line, at the shallower part of the Frank-Starling curve, you get a large increase in lung water. which is really detrimental for our patients. And think of the glycocalyx also. So be conservative. And also an issue is which patients we should treat with goal-directed therapy and with algorithms incorporating dynamic variables, fluid responsiveness. Some 2,800 patients, they were grouped to extreme high risk, and intermediate risk of mortality. And what you can see here, for mortality, you get only a signal if patients were enrolled in studies with a mortality of the control group of more than 20%. With morbidity, in this trial, it turned out that you get a signal also in patients with low risk. I would add some of these trials are relatively old, so we have progressed as a specialty anesthesia, and therefore I would argue that at the moment patients with low risk undergoing low to intermediate risk surgery do not benefit from addressing fluid responsiveness in the OR. And this is emphasized by this relatively recent meta-analysis from Lobo and Rollins. They searched for studies in major abdominal surgery, and here you can see that indeed there is no benefit for goal-directed therapy. And if you look at patients that were part of an enhanced recovery after surgery, so an ERAS pathway, then you get an even weaker signal. So if you have a good working enhanced recovery program, the goal-directed therapy as part of this program does not add to better outcome for the patients. The benefits of goal-directed therapy may not be as clear as has been suggested historically. Overall, decreasing volumes of intraoperative fluid infusion historically. The study suggests that goal-directed therapy may not be of use to all elective patients undergoing major abdominal surgery, and goal-directed therapy may be more of use in the operative care of high-risk patients. I would emphasize this because normally, again, I repeat it, a patient is able to maintain his fluid balance without us. He can do that, also during surgery. Next thing is for my residents. This is a view in my operating theaters, of one of my operating theaters, and the hospital company, they allows free access to the World Wide Web throughout the surgeries, and when I enter a room, sometimes I see stock market charts on the screen. This is, by the way, the chart from Edwards. I'm not paid by this sentence. This is Edwards' stock chart. And the next thing is, this is one of my young residents, and they're sitting there, unfortunately not with Miller's anesthesia, but with her mobile phone. And she is on her way to get a new high score. So anything which she has to react to, like fluid responsiveness or new variables, is only distracting. And therefore I, at the end, still apply for monitoring our patient, for assessing fluid responsiveness, not to respond to fluid responsiveness, but to assess fluid responsiveness, to measure cardiac output. Because even if we admit that these monitors are inexact, these uncalibrated monitors, and also only giving trends, there's a well-known Hawthorne effect, also referred to as the observer effect, is a type of reactivity in which individuals modify an aspect of their behavior and response to the awareness of new variables. So if we give our residents new variables, they have to react on these, they have to think about them, and they have to put their smartphones away for some seconds. Okay, my summary. Fluid responsiveness is not easy to assess in surgical patients. You see passive leg raising is difficult. Dynamic variables fail in up to 50% of patients, and the stroke volume optimization is also not as accurate as we believed before. do passive leg raising if you plan to become good friend with your surgeons. Yes, this is true. So patient risk, type of procedure, and stop signals. Stop signals for fluid administration are key issues. As an academic teacher, I would always say yes, because there are many papers out, many meta-analysis always telling you that goal-directed therapy and fluid responsiveness is a part of goal-directed therapy. So do it. As a head of department, I would say maybe in patients at high risk, I would respond to fluid responsiveness by measuring it and by addressing it. And as a resident, no. Okay, thank you.
Thanks, Berthold. There was an interesting journey through the evidence base for this aspect of our practice. I guess I'll just open the questions by saying the NICE guidelines were quite controversial when they were introduced on the basis of a fairly thin evidence base, it was felt at the time. Do you think that they should be repealed or revised officially?
So NICE is always working on their own guidelines, and they have now a different guideline where they state if you give more than 2,000 milliliters of fluids, seek expert opinion. So in the OR, maybe you call the consultant, you call the head, whatever you mean, but I think that NICE has realized that this stroke volume driven algorithm is always giving more aliquots of fluids and fluids puts the patient at risk to be overfilled, and overfilling is really detrimental to our patient. This weight gain during surgery, and the surgeons have realized that, I think before the anesthesiologists, is very bad for the patients, and therefore we should be very conservative with our fluid management during surgery.
Any comments or questions, Michael?
Berthold, thank you very much for this entertaining presentation, especially when you appropriately said that just because you're over 65 doesn't mean that you're elderly. I agree completely. Several things. When we developed the stroke volume and pulse pressure variation, in our very first paper, we said the primary thing it'll do is prevent you from giving fluids to a non-volume responsive patient, because we appreciated the fact that that was a very dangerous thing to do. Second, in terms of the intraoperative control, if you're measuring cardiac output and you cannot, in their atrial fibrillation, and you can't do a passive leg raise, which is totally appropriate once surgery is started, then you can give small boluses of fluid and look and see if there's a change. And that's what we recommended before. But you can also increase the tidal volume from 6 mLs to 10 mLs for just 10 beats, 10 breaths. And that was recently published. And look at the dynamic change, and that's extremely accurate. And what was the final part I was going to say? So this gray area that you're talking about, I think, is important. But the most important one, I think, for me, and I agree with you, is that when you're giving optimization, it means different things in different patients based on their pathophysiology. And the one thing that I would never do is push a person until they were no longer volume responsive. Because by definition, if you're no longer volume responsive, you are in cor pulmonale. If you were to do an echocardiogram on a person who is no longer volume responsive, you will see paradoxical septal shift and sometimes tricuspid reverse. That is not a place you want to have your patient. So keeping them below 15% volume response is good. The final thing is, when we did the original studies on this, there was a linear relationship between pulse pressure variation, or subsequently stroke volume, and changes in cardiac output. There was no threshold value. It was linear. Now, there was error, of course, but it means if you, and I agree completely with you on the point, if I have a person who I'm not worried about volume because they're bleeding a lot, I'll go with volume in a pulse pressure variation that's lower. But if I'm worried about them having cor pulmonale, pulmonary hypertension, or elderly in some way, I will restrict what I'm doing, because that's what we all should do. It should be our clinical judgment. And I actually give a slide saying, should it be black or white, or should there be a translate? Just because people like rules, and rules, unfortunately, are simple and invariably going to be wrong.
Thank you.
I love rules. I love breaking rules, actually.
So Dr. Pinsky made a brilliant statement, which is that there's no normal cardiac output. It's enough, is what he said basically, to maintain nutrition and biochemistry and so on. So should there be some biochemical measure? Should we be measuring lactate, for example, and give just enough fluid to have the lactate not go up?
Exactly. The bad thing is lactate is a relatively late indicator of insufficient oxygen supply to the organs. Therefore, we believed in central venous oxygen saturation, central venous saturation, but at the moment there are papers coming out that tell us that a low central venous oxygenation does not mean that the patient will develop lactate and that he will have a bad outcome. So unfortunately, central venous oxygenation saturation is not as specific as we would like to have it, and lactate is late.
So we may just need some future vista or some future research or some biomarker for adequate perfusion, because after all, under anesthesia, the whole metabolic rate, oxygen consumption goes down, so you ought to need less cardiac output.
You're totally correct. So it's an unresolved issue yet, unfortunately.
Thanks for a very interesting talk. So as an engineer, not a clinician, I'm struck by the fact that we're looking at global variables, right? Cardiac output, blood pressure, when in reality, should we be looking maybe at regional perfusion, regional indicators of organ well-being for the kidneys or the brain?
That's a very good question. And as you know, the cerebral oxygenation has been advocated as a very specific and sensitive tool for the patients undergoing cardiac surgery, especially. And it turned out that these patients are nearly routinely monitored with cerebral oxygenation nowadays. However, despite the fact that you can post hoc always see that patients with a low cerebral oxygenation did worse compared to patients with a normal cerebral oxygenation, there's no algorithm out to address a low cerebral oxygenation with several measures and then have a good outcome. The kidneys are key, I agree totally, and if we have or would have an indicator variable which could prove a kidney well-being throughout surgery, this would be great and would be the first to test it, of course.
All right. It's an enormous topic and we could talk for hours about this, but in the interest of time, I think we better move on. So thank you very much, Berthold, for that presentation.